patient in the world. Patient who was able to clean this small amount of keratinized tissue for 10 years before the mucogingival line had the time and the chance to realign completely. Does this patient exist? No. No. But we help this patient. How? By giving him or her during the surgery a submarginal connective tissue graft. What does it mean? It means that, yes, I don't have keratinized tissue enough to maintain patient plaque control and toothbrushing trauma for the time it takes for the mucogingival line to reline. Yes, but I want to give stability to this small amount of keratinized tissue to prevent it to shrink by adding a submarginal connective tissue graft that prevents shrinkage, that prevent collapse, and increase the soft tissue thickness. And so thanks to the increase in the soft tissue thickness, the patient can brush with no risk to create a new gingival recession. And so there is time for the mucogingival line to regain its genetically determined position with no problem for the patient maintenance, because even if the patient does not have enough keratinized tissue, immediately after surgery, she or he has enough thickness to brush this area with no risk to create a recurrence of gingival recession. So now the question is, when you don't have enough keratinized tissue, but you have that small amount of keratinized tissue remaining, it's absolutely mandatory to add a connective tissue graft. But the connective tissue graft should not be exposed. The connective tissue graft should not be placed more corner than the coronally advanced flap. The connective tissue graft should be placed submarginal with respect to the placement of the coronally advanced flap to prevent shrinkage, to prevent collapse, and to allow the patient good maintenance phase despite the presence of low amount of keratinized tissue. And at the end of the story, 10 years after, you don't see any side on the graft because the graft is below. But thanks to the realignment of the mucogingival line, now you can see keratinized tissue coming back. And why this happened in this patient? Because this patient was genetically determined for having a good apically position of the mucogingival line that make you be quite predictable in the increase of the keratinized tissue height during the realignment of the mucogingival line. So when we have second Miller class gingival recession, we immediately have to look at the tissue apical to the gingival recession in order to see if there is or not the small keratinized scar tissue remaining apical despite the gingival recession so deep went beyond the mucogingival line. And because if you have this keratinized tissue, you have to use it to give stability to your coronally advanced flap, and at the same time the stability of your coronally advanced flap must be improved by adding a submarginal connective tissue graft below that prevents shrink, prevents collapse, and helps the patient to clean. And the final outcome, you don't see any sign of the graft exposure. You can see the keratinized tissue increasing, the thickness increasing, but the texture and surface characteristics of the patient will be exactly the same of the adjacent teeth. If you don't have at all keratinized tissue remaining apical to the gingival recession, because in this case, the gingival recession as it happens in the lower incisors, lower molar, upper molar, went beyond the vestibulum depth, and so you don't have any keratinized tissue remaining, you have to look at the keratinized tissue lateral to the gingival recession, because sometimes you have good amount of keratinized tissue lateral to the gingival recession to shift the flap and to move it laterally to give stability to your laterally moved flap that is also coronally advanced to cover the root. If the keratinized tissue you can take lateral is thick enough and wide enough, you can make the laterally moved flap by itself. But obviously you need a large amount of keratinized tissue to protect gingival recession in the adjacent tooth to form and to have good amount of keratinized tissue to move. And if you don't have such amount, you can use a smaller amount of keratinized tissue coming from the adjacent tooth to be used as a covering flap for the tooth with gingival recession, but you have to add a submarginal connective tissue graft, which gives, at the beginning, increase in the soft tissue thickness that allows the patient to clean, that allows the mucogingival line to regain its genetically determined position. What is third Miller class gingival recession is that Miller class that in the Miller classification was considered not to be completely covered by a soft tissue up to the cement-enamel junction. So what we can tell to the patient, dear patient, I can cover only some of this gingival recession, only partial root coverage can be achieved, and no patient in the world would accept this, because they only think that the patient is really interested. It's not to cover the most apical aspect of the gingival recession, but to cover the most coronal aspect of the gingival recession. That is that one the patient is showing during the smile. And so what we did is to evaluate what was really patient attract more. Was the really patient attracted to how much we can cover of this patient, or was the patient more attracted by the difference in color between the enamel and the still uncovered root? And in order to do this, we made a very simple study in which the cement enamel junction of the patient was masked by means of Adobe Photoshop, and we asked the patient to judge the final outcome of the same soft tissue coverage. And once the area was completely changed in shape, color, and surface characteristic, and so the patient does not see anymore any difference between the covered and uncovered portion of the root, the patient was judging this as a successful, despite it was not really covered with a soft tissue. And so, from this data, we really changed our way to treat third Miller class gingival recession. Third Miller class gingival recession is the gingival recession with some loss of bone and some loss of attachment, so you cannot cover the cement enamel junction. But if you measure and if you change first with a composite restoration the patient expectation by shifting the cement enamel junction more apically, exactly in the same manner we did for the presence of abrasion defect, you give the patient a final outcome that is not really complete coverage in terms of anatomy, but it's absolutely successful and complete for the patient, because the patient does not see that an area was not covered with the soft tissue, but the enamel is continuous in order to meet the pink keratinized tissue and the red alveolar mucosa. And even if the line of root coverage does not coincide exactly with what were patient expectation before surgery, the patient cannot remember where this line was. And there is no patient in the world that said, "Hey, bastardo, you changed the cement enamel junction of 1 millimeter." It doesn't exist. The patient wants to see harmony. The patient wants to see complete coverage ever, even if complete coverage cannot be achieved. And the only way to achieve complete coverage when you have loss of bone, loss of attachment, is obviously to shift the cement enamel junction a bit more apical. And how can you be more precise in how much you have to shift apical your cement enamel junction? You have to measure the distance from the cement enamel junction angular point, which is called cap, as we said before, to the contact point, because this distance corresponds to the ideal anatomic papilla in the absence of bone loss and in the absence of attachment loss. So that is called ideal papilla, is the height of soft tissue, is the height of the papilla that this canine need to be completely covered. So it's very easy to replace, to measure the same distance from the cement enamel junction to the contact point, starting from the tip of each anatomic papilla, and then to replace on the soft tissue margin the two new caps point, which correspond to where the new cement enamel junction will get into the papilla more apically, but at a good distance from the tip of the anatomic papilla, so that this cement enamel junction can be completely covered by composite restoration. And this line should be shown to the restorative dentist that has to follow it with a diamond bar 0.5 round in order to create such a chamfer, small chamfer along the root surface that create good condition for the adhesion of the composite restoration. And only the apical aspect to this line will be covered with the soft tissue. And so the first thing we have to do is to use this apical aspect to be covered with the soft tissue for the clamp isolation, clamp application, rubber dam isolation, composite application in a very isolated operative field. And now you can use your keratinized tissue to be well adapted above the very convex, clean, smooth surface, and so good aesthetic outcome will be achieved by the patient, even if this was not exactly what the patient expectation were before surgery, because it is really more apical, about 1.5 millimeters, 2 millimeters more apical. That is how much papilla, how much bone, and how much attachment was lost. And also, in terms of maintenance phase, you change a situation in which the cement enamel junction was so shift corner with respect to the tip of the papilla that now a new emergency profile was created with good amount of keratinized tissue, good soft tissue thickness compared to the composite restoration. And this was done by making first the composite restoration and after the coronal advance flap. And if you look again, what we call sleeping tooth and the situation before and after, you can see how much work was made in order to change patient expectations. So it's very important that we make the all restorative and surgical phase in the same setting, in the same surgical setting on the same day of the surgery, so the patient will not be aware how much of the success depends on the composite restoration, how much of the success depends on the surgery. But what is very important is that the final outcome is really successful for our patient.